Hello, good morning and welcome everyone to the 14th and last lecture of your oral histology course. We'll be talking about the temporomandibular joint. This is Dr. Siham Al-Arish. I hope you will enjoy this lecture. Firstly, we'll talk about the gross anatomy of the TMJ, and then we'll go into the microscopic histological features of the articular surfaces, intraarticular disc, synovial membrane. We will talk later about the developing condyle, and lastly, an overview of the clinical considerations. So the definition of the temporomandibular joint, it is a synovial articulation between two bones, the mandible and the cranium, and more specifically the temporal bone of the cranium, of the skull. It was previously called the craniomandibular joint also. The synovia is a thick, clear liquid that could be found. It is a type of joint where there is a liquid that helps in moving the bones. This synovial articulation allows for many movements in which the hinge joint movements, which is open, closing, anterior, up and down movement, and the gliding or the translation movement, which is the other directions, also to forward, backward, and extrusion, intrusion, to the lateral and medial movements of the mandible. What is also characteristic about this joint is that the articular surfaces are covered with a fibrous tissue, and it is a center also of cartilage, the intramembranous bone formation. Until the adolescence, the mandible or the condyle is an ossification center, where the cartilage is being ossified into bone under the fibrous surface. Lastly, the joint cavity is divided by a disc called an intra-articular disc. It is divided in two spaces, an upper cavity and a lower cavity. Here we see this articulation between the temporal and the mandible. Most importantly is the articular disc, which separates into a superior and an inferior joint cavity, and all of which are surrounded by an articular capsule. The gross anatomy of the temporomandibular joint. Each of the bones in the upper and lower compartments is covered by a fibrous tissue. We see the articular disc separating into two synovial cavities. The synovial cavity here in which fills the liquid, which is secreted to lubricate, mostly to lubricate the movement of the joint. Now we will start about the gross anatomy. We will talk about the mandibular fossa, the upper articular surface, the mandibular condyle, the lower surface, the surrounding capsule, the temporomandibular ligament, accessory ligaments, and finally about the articular disc. So the mandibular fossa, it's the oval depression in the temporal bone, which is anterior to the acoustic meatus, external acoustic meatus. There are variations inter-individually in the curvature of this fossa. Can be caused maybe by the occlusion in each person. The intra-articular disc, it molds the shape between the fossa and the condyle. So it adapts with the shape. The mandibular condyle, the lower compartment, also it has a variation in size and shape. The long axis is surely not at right angle with the ramus. So it is convex anteriorly and superiorly, where this surface of the condyle meets the concave articular surface of the mandibular fossa that we talked about. Lastly, it joins the ramus through the neck of the condyle. Here, as we can see, the mandibular fossa posterior to the articular eminence, which is a shallow depression, and the condyle, which is the head of the condyle, is a convex surface, and it joins the mandible through the neck. So in between these two articulation surfaces, we have the articular disc in between the upper and lower synovial cavities. Then we talk about the articular capsule. It's a thin cuff of fibrous tissue that covers the interior and exterior temporomandibular joint. It does not limit the movement because it is too weak to provide any support for the joint. So externally it is attached to the glenoid or the mandibular fossa, the articular eminence, and the neck of the condyle. In the posterior portion, it is associated with the connective tissue of the disc, and from the internal side it is attached to the interarticular disc, and it is lined by the synovial membrane where the fluid will be secreted. It is a richly innervated capsule. The synovial membrane lining the inner surface of the capsule and the disc. It does not cover the articular surfaces, and it secretes the synovial fluid that fills the joint cavities, lubricates the joint, and has a nutritive function. So here we go, the mandibular fossa and the head of the condyle articular surfaces. The intraarticular disc, which is attached posteriorly to the capsular ligaments. We noted that the capsular ligaments are very weak to limit the movement or to make any support. The temporomandibular ligament, or it's called the lateral ligament, this is what strengthens the joint capsule. It is the main ligament that restricts any distal and inferior mandibular movements. It resists also dislocation during the functional movements. It starts in the lateral surface of the articular eminence and is inserted into the posterior surface of the condyle. You see how it helps in the hinge movement or anterior medial movement of the condyle. you have the main lateral or temporomandibular ligament, plus many accessory ligaments, part of which are the stylomandibular ligament from the styloid process to the mandible angle, the sphenomandibular ligament starting from the spine of the sphenoid bone to the lingula in the mandible, the pterygomandibular ligament, which extends from the pterygoid hamulus to the retromolar region of the mandible, and the retinacular ligament from the articular eminence to the fascia of the masseter muscle. Here we can see the main temporomandibular ligament and some accessory sphenomandibular ligament, stylomandibular ligament. Finally, the articular disc, it is a dense fibrous tissue. It has a blood vessel enrichment from the peripheries only, not in the center. The upper surface is concavo-convex from anterior-posteriorly, while lower surface is concave to adapt with the shape of the head of the condyle. So posteriorly it's the thickest part, while centrally it is the thinnest. Lateral half is thinner than the medial half. Lateral half where it is limited by no solid boundaries. Again, this is the articular disc. From the extremities, anterior and the posterior portions, it is a fibrous tissue where the collagen fibers run in a anterior-posterior and medial-lateral directions. While in the central portion, as we said, it is the thinnest and runs in contact with the articular surface of the condyle. So the collagen fibers here, they run only anterior-posteriorly in a more, let's say, regular direction and loose arrangement. So the attachments of this articular disc, it merges with the capsule on peripheries. Anteriorly, it is attached by the fibrous bands to the superiorly the anterior margin of the articular eminence, and in the inferior it is attached to the margin of the condyle as seen in the picture. Medially and laterally, as we said, it is attached to the capsule. Posteriorly, they are attached also to the capsule by a bilaminar zone composed of a retrodiscal lamina called superior and inferior lamina. So as we said, the articular disc regions, posterior, intermediate and anterior zone, and from the posterior thickest point, it is attached to the capsule by the superior and inferior lamina, while it is attached anteriorly by fibrous bands. To the bony regions. Here we go, the posterior, intermediate, thin zone, and the anterior bands of the articular disc and its attachment to the capsule, fibrous capsule, appearing in green color. Lastly, we talk about the innervation of the TMJ. It is richly innervated by most prominent branches are the divisions of the trigeminal nerve, the mandibular branch of the trigeminal nerve, which goes into the auriculotemporal, masseteric, and the deep temporal nerves. It has a proprioceptive nerve endings for mastication and also free nerve endings, the nociception. Lastly, we'll go through the histology of each part of the sections that we described.